Good morning, everyone. I'd like to start off by thanking the organizers for inviting me to give this talk. And I'm quite interested in learning a little bit about the new hip fracture care model that will be presented just right after me. So the definition of osteoporosis is a progressive systemic skeletal disease characterized by low bone mass, a decrease in bone mineral density, which leads to an increase in bone fragility and a greater likelihood of fracture. And as you can see from the two diagrams below, individuals with osteoporosis have very thin bones, they're less bone structure, and as a result are more likely to fracture. So the prevalence of osteoporosis is quite high. 1 in 4 women and 1 in 8 men over the age of 50 have osteoporosis. So about 25% of women and 13% of men. Now, to put this in perspective in absolute terms, in 1993 it was estimated that 1.8 million women over the age of 50 have osteoporosis based on that bone mineral density definition. And you can see from the graph below that the number of women with osteoporosis increases with age, and that approximately 1 million women over the age of 70 have the disease. So this graph shows the actual prevalence of fractures in the population for women 50 years of age and older. So we looked at hip, spine, and wrist fractures. And I'd like to point out for the spine fractures, these are only clinically recognized spine fractures. So I like this slide because it shows it compares osteoporotic fractures with other diseases. And this data is from the United States and calculates fractures on an annual basis. So what the results show that there's about 1.6 million osteoporotic fractures that occur in the United States annually. And this is higher than the combined totals of stroke, heart attack, and breast cancer. So now I'd like to talk a little bit about predictors of fractures. And the two classic predictors are bone mineral density and age. And as you can see from this graph, that as femoral neck bone mineral density T-score decreases, the likelihood of developing a fracture over the next 10 years increase. Such that for the highest bone mineral density, there's an 8-fold increase in the likelihood of developing a fracture as compared to the worst case scenario of -4. In addition, age is an independent predictor of fracture risk. And as you can see, for example, if we look at a T-score of -4, individuals age 50, which is represented by the red line here, have about an 18% chance of developing a fracture in the next 10 years, as compared to 80-year-olds, which are represented by the blue line here. They have about a 44% chance. But in general, I think physicians place too much emphasis on bone mineral density in assessing whether a patient is at high risk for developing a fracture. And this slide demonstrates this. It's the NORA data. They looked at 150,000 postmenopausal women with a mean age of 64. And what they did, they divided the women based on their bone mineral density T-scores, which is shown in the x-axis here. And this dotted pink line represents the BMD distribution of these women. So you can see the majority of women do not have osteoporosis, but are osteopenic. Now, these are the results here. So the gold bars represent fracture rates, expressed as fractures per 1,000 patient years. And you can see as bone mineral density decreases, the fracture rates increase, which is to be expected. And this dotted line represents the osteoporotic threshold. So everyone to the right of this line has osteoporosis. So you can see the highest rates of fracture occur in individuals with osteoporosis. However, these blue bars represent the actual number of women who had a fracture. And based on these results, over 50% of fractures occur in women without osteoporosis. So now I'd like to talk about the consequences of fracture. The first, there's a huge economic burden associated with fractures in Canada. In 1993, it was estimated that the healthcare costs related to fractures was 1.3 billion Canadian dollars. And if we divide this number into acute care and long-term care, the acute care costs, including hospitalization, outpatient care, and drug therapy, the cost would be about $465 million. And $842 million were set aside for long-term care and chronic care. Hip fractures also have a significant impact on individuals. In this study, they looked at the morbidity associated with a hip fracture 1 year following that fracture. And 30% of individuals were still disabled. 40% were unable to walk independently. And 80% were not able to carry out at least one independent activity of daily living. For example, going to the grocery store or driving a vehicle. So finally, I'm going to talk about the care gap, and specifically the Canadian Quality Circle Project, which was used to reduce the care gap for family physicians. Now, despite the high prevalence of osteoporosis and the negative consequences associated with fractures, and even though we have available technologies to measure bone mineral density, such as DEXA, and we have very effective therapies for treating the disease, some of these therapies reduce fracture risk by 50%, and some of them work within 6 months of starting treatment. And we have evidence-based guidelines on how to manage osteoporosis. These have been published in 1996 and 2002. Despite all this, there still is a care gap in managing the disease. And this slide exactly shows the care gap. These researchers examined the evaluation and treatment of patients 1 year after fragility fracture. And you can see the results here. Less than 25% of individuals after a fragility fracture had a DEXA scan. Less than 20% were diagnosed with osteoporosis. Very few individuals were on vitamin D or calcium, and less than 10% were on bisphosphonate therapy. Now this slide even is worse, and this is for hip fractures. So these research showed that less than 5% of individuals who had a hip fracture were diagnosed with osteoporosis, had a DEXA scan, or were on any osteoporosis medication. So because of the care gap, we decided to conduct the Canadian Quality Circle Project, which was designed to improve family physicians' adherence to the 2002 osteoporosis guidelines. So some of the observations of Quality Circles was that this project addressed several important areas of osteoporosis management, including risk factor identification, appropriate B&D testing, and appropriate therapy. So it encompassed all the management of osteoporosis, the use of Quality Circles of effective knowledge translation approach that improves family physicians' adherence to the 2002 osteoporosis guidelines. In addition, we didn't expect 100% adherence to the guidelines because patient management also depends on clinical judgment and patient preferences. And the final point I'd like to make is that Quality Circles may be effective in other patient populations or other physician groups. So my overall conclusion is that we found that the prevalence of osteoporosis is quite high, and the consequences of the disease are dramatic. Not only does fractures change a woman or man's life, it could also end that person's life. While we have effective therapies that can treat osteoporosis, there's still a huge care gap in the management of the disease. And that care gap may be reduced through targeted educational interventions.